summarize the answers to your question, we will appreciate that they will be transmitted by chat in English language. En français, donc bienvenue à tous. Je suis ravi de présenter Paul Sessink. C'est très clairement le leader mondial en matière d'exposition aux médicaments cytotoxiques. Quand nous, on a travaillé sur Lyon sur ce sujet de l'exposition des manipulateurs de chimiothérapie, dès la fin des années 90, c'était déjà le leader mondial avec Thomas Connor. Voilà. Donc, le webinaire Equashield sera organisé est organisé par Palex Medical. Il sera en anglais, mais les diapositives seront découpées en deux parties. Une partie sera en français, l'autre partie en anglais. Paul s'exprimera en anglais, mais il y aura un sous-titrage en français. À l'issue de chaque partie de Paul, il y aura un résumé que je réaliserai brièvement. Et au cours de la présentation, vous pouvez écrire en langue anglaise vos questions et on pourra les donner à l'issue de la présentation qui durera à peu près 45 minutes à Paul. Voilà. Donc, je laisse la parole à Paul. Paul, it's okay.
Okay. Can everybody hear me? Okay, let's have a look. Yes, welcome to my presentation in collaboration with Equashield and Palex. I'm very happy to do this presentation, and I will go in some details about cytotoxic exposure and monitoring and risk related to this. And first of all, I would like to give a disclosure that I am a manager of exposure control already for many years, and that I was paid for this presentation. This is a little bit about my background. I'm a chemist. I studied chemistry and already many years ago, and so I'm not a pharmacist.
Paul, we don't see the PPT.
You don't see the PPT? Let's look.
The green share.
Yeah, okay, let's have a look. I have to go back. Sorry for that.
Okay. No.
You see it now?
Yes, okay.
You see it still? It's
yes.
Okay? Okay, yes. I'm very sorry for this. Just return to the previous slide here. So my background here, I'm a chemist, so I'm not a pharmacist or a nurse or whatever, but I have some experience on the issues when it comes to cytotoxic drugs, risk assessment, monitoring, and so on. And I started my company, Exposure Control, already in '95. And what we do, we focus on monitoring exposure. And we recently started also with antibiotics, another group of drugs. I had a PhD in medical science in '96, so that's a little bit about my background. And if you want information or visit our website, here you find the details. Okay, today I will have my presentation about cytotoxic drugs. I will talk a little bit about the toxicity and the risks, but I will focus more on contamination studies, how to manage this, and about exposure assessment studies. It's very broad. I will talk about kinds of testing has been done in the Netherlands, in Belgium, but also a little bit in France. So you will be guided how things are in France. End up with conclusions, recommendations, and then I will talk shortly about new regulations coming from the European Union. Cytotoxic drugs, there are different types of effects, and you see here the two groups, the acute effects and the delayed effects. Acute effects are effects that are mainly happening on short term in patients that are treated with cytotoxic drugs, cancer patients, but also other patients. They will have all these kind of effects. Can be on organ level and bone marrow suppression that's frequently found. When it comes to occupational exposure for workers in hospitals, then the delayed effects are more and more important. That are effects that happen after probably many years, many months, and these include reproductive effects. We have seen studies showing spontaneous abortions, low birth rate, all kinds of effects that can happen for nurses and technicians who are working with cytotoxic drugs. But also we have seen menstrual dysfunction when people are highly exposed. What is relevant here is the carcinogenicity. Carcinogenicity means that these drugs at a very low level when you are daily exposed can cause cancer. And that's relevant and very important to know. So that means due to the properties of these drugs, the carcinogenic properties, you have to have a very good protection to be prevented from exposure. Nowadays, we have already 29 cytotoxic drugs considered as carcinogenic. And when you compare this with about 20 years ago, then it was about 10 drugs. So the number of carcinogenic drugs is growing due to the fact that we have more studies showing the effects of these drugs. Maybe summarize for you, Bertrand.
Ok. Donc là, le résumé sera relativement court, hein, pour ceux qui l'ignoraient, mais c'est quand même assez improbable. Très clairement, il y a une vraie toxicité intrinsèque des produits cytotoxiques qui ont été très clairement démontrés au niveau des patients, et donc c'est des produits qui sont bien entendu manipulés dans nos différentes unités, et donc les toxicités principales, mutagènes, carcinogènes et tératogènes, qui font considérer ces médicaments au sens du Code de la santé publique comme des médicaments dits dangereux. Ok, Paul. Okay, Paul.
Okay, thank you. And we will proceed to the next slide. When it comes to protection, and it's sure that you have to protect yourself when these drugs have these chemical properties, toxicological properties, then you follow the hierarchic order, and that's indicated here. And this order means that you have to take safety steps to protect workers. It's a kind of strategy you have to follow to prevent exposure. And actually this is in 4 steps, it's indicated in 4 steps. And the first 2 steps are prevention, and the last 2 steps are protection. And it's very clear that if you prevent yourself 100%, then you need not to protect yourself. So that's very important to have the focus on prevention. And what you do in general when you prevent people from being exposed, then you replace the drug by another one. But this is not possible for cancer patients. It's very simple. Cancer patients, they need a specific drug to be treated, so you cannot replace the drug by another one. The next step, what you do is then you move to reduction of sources of exposure. And that is often, it's rather complicated, but it can be done by simply closed handling. When you do containment, you contain the drug from being in contact with workers in terms of closed handling. Then you can protect people from being exposed. So nowadays, when you talk about closed handling, then it's mainly the closed system drug transfer devices that are the option for closed handling. The third step, and that's what you see in the pharmacies mainly, is that ventilation. It's a way of protection. If you have a good ventilated room, like clean rooms with cabinets and isolators, then you can protect yourself from air that can be contaminated with cytotoxic drugs. And also ventilation is important when it comes to nursing on departments where people are treated and given the drugs. Finally, what you do is, in the end, you take personal protection, and that means that you put gloves on, you have gowns, masks, special clothing, and that's the way you protect yourself from being exposed. But mostly relevant is to start first with step 2, step 3, and finally take step 4 if there are no other options. But mostly the 3 combinations are in practice nowadays. When we talk about closed system drug transfer devices, then there is a lot of debate on how you should define these devices. And actually, when you look more in detail at what is known about a definition of a CSTD, then we have actually one main that is mainly followed, that is from NIOSH, from the United States. And there it's indicated that a CSTD is a drug transfer device that prohibits the transfer of environmental contaminants into the system and escape of drugs outside of the system. That's a roughly definition from NIOSH. And when we look to ISOP, that's the International Organization of Oncology Pharmacy Practitioners, then they say, well, you can more or less see a CSTD should be airtight and leak-proof. That's quite common and good statement about a CSTD. In Europe, European Union, we have no harmonized definition for a CSTD. When you go to the directives, the carcinogen mutagen directive, it's indicated that you have to work in a closed way, but it's not defined how that should be done. It's a very vague description, a closed handling. And so there is no real definition in the European Union about CSTDs. Just to give you some examples, we have here 2 types actually. This is just a few of the examples. There are a few more, but let's have a look. There you have here the filter technology. So that means the devices, the CSTDs who have a filter inside. And here the barrier technology CSTDs, which have an effective barrier between the drug and the worker. So here you have the Chemolog Facile Equashield as a barrier technology CSTD, and here the chemoclave adapter and the filter technology. These are the most common, I think they are in place nowadays in Europe. When we talk about occupational exposure to cytotoxic drugs, we have to consider actually 3 issues, 3 routes of exposure. The first one is inhalation. So inhalation is actually what is coming in your nose via your nose and mouth into your body, but mainly the nose. These are particles and vapors. That's the option that could happen. Ingestion is actually what you get in your mouth and actually eat, more or less. And for that, we have the so-called finger shunt effect as an option for being exposed by ingestion. And it's very simple. It's just what you have. If you have something in your hands, you can put it in your mouth and then you can absorb it. But in the end, the most important one is absorption through the skin. So therefore, I indicated this in red. Absorption by the skin is a very, very important issue when it comes to cytotoxic drugs, and actually the most important exposure route. And that happens when the skin of workers gets in contact with contaminated surfaces. And these surfaces, these are on the workplace, on tabletops. They can be everywhere where cytotoxic drugs are handled. But finally, the final uptake, so the total exposure, is a combination of these and is also related to the use of PPE, personal protective equipment. For instance, as an example, if you have very effective PPE, and there is still contamination, you will not be exposed. But mainly when we go, for instance, to the nursing departments and the administration areas, PPE are not often that good and in quality that effective. So a lot of people will be exposed when it comes to administration of the drugs. Bertrand.
Okay. Pour résumer en fait cette partie, très clairement, on a des stratégies de protection pour nos équipes alors, qui sont différentes entre les unités de soins et les unités qui travaillent en pharmacie. Mais il faut essayer d'associer à la fois les équipements de protection individuels que vous connaissez, les systèmes de manipulation sous PSM, sous PSC, sous isolateur, et bien entendu, comme l'a dit Paul, les systèmes clos qu'il vous a présentés ici. Ce qu'il faut également retenir, c'est qu'en dépit des différentes protections qu'on utilise, il y a une possibilité d'exposition, il y a plusieurs voies d'exposition qui sont proposées, mais qu'il faut qu'on retienne que c'est la voie d'exposition d'origine cutanée qu'il faut retenir comme la voie principale d'exposition. D'où, quelque part, je vais anticiper un petit peu, mais les techniques d'évaluation de la contamination d'environnement autour des différents travailleurs, que ce soit encore une fois en unité de soins ou au niveau de nos équipes en pharmacie. OK, Paul.
Okay, we continue to the next one. Important to know is where is the contamination? What are the sources of contamination? And when we go to the pharmacy where the preparation is done, we see that the vials that are coming in are often contaminated. All these drug vials that are produced in the pharmaceutical industry can be contaminated on the outside. So you have to be aware that where you touch it. Of course, we have to deal with spill when preparation is done in a biological safety cabinet or in an isolator. It doesn't matter what of these two. In both cases, you have spills. There will always be spills where you do preparation. And then, of course, we have to deal with waste, the waste of the drugs that are prepared. When it comes to administration, inpatient and outpatient nursing in the wards, then we have, of course, to deal with the products we receive from the pharmacy. And it's often shown that bags or syringes that come from the pharmacy on the outside are contaminated. So when nurses or technicians or maybe nurses get in contact with these, then you can be exposed via the skin. Then we have also to deal with patients. The patients, they have a lot of drugs in their body. So urine, sweat, vomit, and all these kind of products can be contaminated. Of course, a lot of spill is happening there during the administration, and that depends on the handling. And the handling is often that people open systems, disconnect systems where there is a potential risk of exposure. Of course, the waste, but also bed linen and clothing. Patients, they sweat a lot and they once in a while urinate in beds, and then the bed linen, the clothing can be very, very highly contaminated. So the risk of contamination is important to know that it can result in spread and potential exposure of the workers. So you have to really protect yourself because the drugs can be everywhere. When it comes to checking the environment, because when we work with these drugs, we have to validate, we have to check how we do things, and we have to find out, is there exposure and to what level is there exposure? There are actually two ways to do it. It's called monitoring, and you can do environmental monitoring, and you can do biological monitoring. Here are the two differences. Environmental monitoring is actually that you measure the drug in the environment. So that can be in air, that can be on surfaces, but it doesn't give you information if it's in the body. If it's in the body of the worker, it's only the drug in the environment. And it gives no information about potential health effects. So that's not provided by environmental monitoring. But if you go to the biological monitoring, there is what we do. You measure the drug in the body, mainly by urine testing, sometimes with blood testing, but mainly with urine testing. And with that information, you can make a risk assessment for the workers. What does it mean if I have so many of these drugs in my body every day or every month, every year on the long term? Does it result in adverse health effects? This is mainly done by the urine testing. Well, we have seen over the last 20-25 years a lot of wipe sampling studies. Many of these studies have been done, and they are favorable because they are quite easy to do, and it also gives good information about how things are performed, and also if the cleaning that is finally done is okay. I will present later on some of the wipe test and some of the urine test results. When we do wipe testing, just to give you an example, in the preparation in the pharmacy areas, we have the packaging, which can be contaminated. We have the vials. We have all kinds of desks where people work. We have here the biological safety cabinets, but it's also the same for the isolators. Isolators and biological safety cabinets, they are exactly the same. many people think that isolators are much safer than biological safety cabinets, but I think that's not true. And we have seen studies showing that we have also problems with isolators when it comes to contamination in the environment. Here you have kind of waste areas, and here a transport container, a tube that is sent with the bags inside via a kind of transport system into the hospital. So all kind of packaging here and all kind of containers shipments can be a part of wipe testing. Here we have administration, where the drugs are given to the patients. Just some examples here: a desk near a patient's bed. Here all kind of remote controls that are used, pump systems for infusion. Here we have the pools, we have a bed area, the floor, the toilets of the patient, waste area, all kind of positions that can be contaminated with drugs. And here we have the laundry of the patients, the bed line, and all kind of things that can be contaminated by urine or otherwise from the patient. When we do surface wipe sampling, I will just do it very quickly. It's quite simple. You take a surface where you work, where you expect contamination, in this case, this table where drugs are checked, and then you define the surface. You can have here a container, the inside where the prepared bags are transported to the nursing departments or the administration areas. And what you do, you drip the liquid on the surface. You can see it here with all the drips. And then you take with a tissue, you wipe this surface clean. Finally, this wipe is going in the container, and the container is sent to the lab. And there, it's very short here presented. We do the preparation and analysis. The container with the tissue is extracted and shaken, and then we do some some pre-treatment to remove particles, not to destroy our system. You get a clear sample in a vial. We add an internal standard, and we put this in the LC-MS system just to give you a short presentation how it looks like. This is unfortunately turned aside, but what you get for, in this case, 7 drugs, which you can analyze in one sample. At the same time, you get here all the peaks. And the peaks, this was done in about 10 minutes run. You can have directly information how much of these 7 drugs are in the sample. And then finally, we calculate the contamination on the square centimeter area of the surface. Okay, here are the surface wipe test studies. So what do you do with this? What does it mean? And it, as I said, it's done in many places nowadays, more or less also as a standard test. And what do the results mean? Well, you measure contamination, and you measure the contamination at the time you do the test. So it's not from the day before or 2 days ago, but it's that moment you take the test. You measure the contamination, and it can be spread, and it gives information of potential risk of exposure to the workers. As I said, potential risk because you cannot estimate the exact risk. And what you do next is that you compare the results, and you can do it in several ways. You can do benchmarking. That means that you have that you compare your results with that from another hospital or another country or whatever you want. But you can also do a periodical check, so that you do it in your hospital every 6 months or every year, the same time. So you can check if it's getting worse, if it's getting better, if there are any improvements. And you can, of course, do an indirect relation with exposure limit values. You cannot do a direct relation because there is no relation between contamination on surfaces and risk, but indirect you can do it to give a kind of an estimate. There are pitfalls. Don't think that surface wipe tests are the best you can do. It's an option to do testing, but it's relevant that if you do this, that the surface that you wipe should have a relation with a potential risk. So it's not relevant to measure on surfaces where there is no contact possible or where people cannot be in contact with. The area is also important. You need a minimum surface area. You have to select a number of drugs. One drug gives information, but not enough. It's better to do more in a test. And of course, what you find, the results you find, depends on the sensitivity of the test method. You can do pre and post cleaning tests. So when you do a pre-cleaning test, then you measure the contamination, how it is, by the handling activities. But there are also hospitals who do a post-cleaning. They say, well, we know that the environment gets contaminated, but we want to be sure that it's clean after, that there is no contamination after cleaning. So they do a kind of a post-cleaning to check the effect of cleaning. But what you should also think about is the risk or the effect of the vials. The contaminated vials getting into the pharmacy area can have an effect on the contamination you will find again. So bias the results. I will present some studies now, just a few to give you some ideas, some impression. This is a study we did in the Netherlands in 2010-2015, and quite a lot of samples here, close to 2016 hospitals, about close to 700 in the pharmacy, a little bit more than 1,000 in clinics and wards, and we tested for these drugs. Cyclophosphamide, platinum drugs, methotrexate, 5-FU, and a few ifosfamide, but these are the main ones. Actually, what it shows, the results, is that 400, close to 500 were positive. So that means less than about 25%, 27% was positive. Mainly it was cyclophosphamide, the platinum drugs, and to a less extent methotrexate and ifosfamide 5-FU. And there were a few very high positive samples, cyclophosphamide, methotrexate, and mostly were related to patients' toilet, what you can expect, because when patients go to toilet, there is a potential risk of quite a lot of exposure there, a lot of contamination. And we also found that most were positive in the administration, so at the nursing area. 1/3 of the samples were positive in administration and less in preparation. And this has all to do with the patients that are in these areas. Here more in detail, percentage of positive samples in preparation. And what you see here is that most of the percentage, the highest percentage, is mainly found around the cabinet where you do the preparation. That will be roughly the same when you use an isolator. There will be not so much differences if you would have done it in the same situation. So that will give quite a lot of contamination. Number of positive samples is quite high in the cabinet area. And here, this is outside these areas, and this is mainly related to vials that are used and coming in from the pharmaceutical industry. When we go to administration, we see quite a lot of positive samples here, close to the patient. So that's the patient room, the bed, the chair, the floor in that area, the patient's toilet, all kinds of things close to the patient, directly related to the patients. But also the toilets of the staff, some medication areas, other rooms where you have to deal with waste. So actually you see that it's more or less spread everywhere when it comes to administration. When we had these results, it's very important to find out what do you consider as okay and not. And because when we have our sensitive techniques nowadays, we can measure very, very low levels of contamination. And it's also important to know what can we consider as okay and not okay. And well, what we did in the Netherlands in 2010, we had a benchmark. As I said, the benchmark is that you compare studies from results from hospitals. That's what we did in the Netherlands. And we had about 11,000 wipe samples in this period, 2006 to 2008, collected in 50 hospitals. And I think this is roughly half of the hospitals in the Netherlands. And we set an alert level at 95th percentile of the results. And then we set an action level, which is in agreement with the European Union Health Council method, 100 times higher. And that resulted in alert and actions levels of 0.1 and 10. So this is 0.1 and this is 100 times higher. What we also found, if the surface contamination with cyclophosphamide, and that was the marker where we were also able to detect in the urine and not only on the surfaces, was below 0.1 nanogram per square centimeter, we didn't find cyclophosphamide in the urine, so indicating no measurable exposure of the workers. So we concluded when we have this level 0.1 and we have no positive urine samples, that could be considered as a safe, and it's never 100% safe, but it's quite safe. So we indicated this as safe, and we said 100 times higher is not acceptable. So that's really too much, but below 0.1 can we consider as a quite okay. And if you want to read this information, you can go to these websites where you can find, it's unfortunately in Dutch, but there you can find the background of these values. And what we do next, or actually what I do next, is I put colors on these levels of contamination. So if you have the alert and action levels for surface contamination, as we have in the Netherlands, you can put colors on it. And the contamination is indicated here. It's nanogram per square centimeter. That's the standard way you express it. And then we said, well, we consider safe as green. So that's below the 0.1. And the not acceptable one is a bit higher than the 10. So that's the 100 difference as I talked about previously. And then in between, there is, you could say a zone where you can split it in two other parts, yellow and orange. And you can, depending on the results, decide what to do. So what we said here, if it's green and it's okay, then you repeat the testing every year. When it's red, then you have action, immediately action, and you have to check the measures which you take again with the white testing because you want to have it lower. It has to be reduced. Here in between, it depends a little bit. If you have a lot in the yellow ones, then you are quite close here. So you have to take care that it's not going to orange. And when you have quite a lot in orange, you don't want to have it going to red. So you have to reduce it, get it to yellow or green. So depending on the total results, you have to take actions in the terms of taking measures or and repeat the testing after 3 to 6 months. So this is a kind of a concept related to the alert and action levels we have in the Netherlands. I will go to some wipe test results, wipe test studies we have done. Here is one in the United States. It's just a few examples. The United States, this hospital is doing tests every year. And I presented not all the years, but only the first 2 years and the last 5 years that they did the testing. And this is just an example for ifosfamide. You can have more drugs, and they did more drugs, but this is just an example. And they took the samples in oncology, in pharmacy, and in another pharmacy. And it's the different surfaces. They took the samples. Sorry, I have to go back. Here you see the preparation room, nursing desk, and pump systems. Here you have the chemo hood, preparation counters, preparation chair, and here on another hood, floor, and table in another pharmacy. And here you see with the colors immediately what the problems are. So the problems are here. The preparation counter and the chair, it's for many years, it's the problem here. And here too, the preparation chair, as I said. So a lot of problems are in this area. Here it's quite okay. Oncology, it looks quite good. There was just one here, but that was long ago. It seems that it's now all solved here. And here we have the other pharmacy. You see here, there's almost no contamination, just a little bit returned here. But overall, this looks quite good. We go to another hospital in Belgium, 2013-2019. This is a pharmacy where they checked cyclophosphamide. And here you see we have a lot of different type of surfaces, gloves that were used, bags, a floor, side walls, working surface of the hood, the scale, mouse, keyboard, phone, and so on. A lot of different surfaces. And they repeat it also every year. You see the results here. And then they had some contamination in 2013. It's diminished, but it came back here in 2016. And here they decide to implement a CSTD. So they used a closed system drug transfer device. And then finally, in the end, it returned to all very, very low levels. Then we have another study in the United States I did many years ago. It's also with a CSTD where you implement a closed system drug transfer device. This is 22 hospitals in the United States in this period. In the pharmacy, this is the example for cyclophosphamide, median values. And you see the surface in the cabinet, the airfoil, the floor, and the counter were prepared. Infusion bags are checked. Quite a lot of positions here. And when we have the standard technique, you will find median contamination like this. So it's mainly yellow and orange. And when you change the procedure by using closed system drug transfer device, you see it's reduced to green. It's only this one is still yellow, but anyhow, if you compare this with this, it's substantially lower. Then in the United States, they had NIOSH, the alert coming in 2004. So there were a lot of changes implemented. So we did the testing again in 2005, 2010, in 30 hospitals in the United States. Same type of surfaces. Surface, we see airfoil, floor, and counter, little bit more positions. And here with the standard technique, again, the same results as we have here before. And after the CSTD was implemented, it's substantially reduced. And you see these values are actually more or less the same as here. So a significant effect of the implementation of a CSTD on the contamination in the environment. This is the wipe testing. Now we will move to the urine testing. And as I said before, the wipe testing is only for the contamination in the environment. It's not related to exposure and risk. But when you do urine testing and you find positive urine samples and you have the drugs in your urine, for instance, in this case, we checked for cyclophosphamide. If you have these drugs in your urine, then you know that you have been exposed. They cannot be in the urine without being absorbed by your body, inhaled or via the skin. And this is just an example where we have done let's have a look, it's moving back. Where we have done 4 studies in Europe, pharmacists, nurses, and doctors, 41 persons, 1 day urine collection. So we checked for 1 day, and then you see it's this level, the mean amount, and it's some people have nothing and others were a little bit higher exposed. And it's also with another study with pharmacists, nurses, pharmacists, and pharmacists, showing that these levels are above this level, which means that there is an additional risk for these workers to get a negative health effect. We also did a study in Japan, that was a few years ago, and there we checked the family members of patients. So patients go to the hospital, they got an infusion or a treatment, and then they move home, they come at home, and then they stay at home for the rest of the time. And these people these patients, they get, they go to the toilets at home, they get a shower, they meet other people and so on. And what we did, we analyzed the urine samples of the female members of the patients. So the men, they got treated, and the females, we checked their urine. And what we found in this case, for 2 persons during 2 days, we found a very, very high level of positive urine samples, a very high much higher even than for the pharmacists and nurses and doctors we found here. So really very high exposure. So that means actually that family members who have patients at home are really at risk for being exposed to cytotoxic drugs, which is shown in this study by cyclophosphamide in the urine. Now we move to a study that is done in France. And this is done 2008-2012. So again, a study, this was on oncology wards in 12 hospitals, 166 workers, nurses mainly, but also staff. They used protective equipment, 3 to 28,000 doses, pre and post shifts. So they took urine before and after work during 2 to 5 days. And there was also done some surface wipe sampling analysis with LC-MS, what we did before. And the Institut National de Recherche de Sécurité, they did this study. The results were actually what we could expect because it's not really new. You find this everywhere. A lot of samples were collected, 181 positive from 11 hospitals, 92 workers, at least one positive urine sample, indicating and divided over the 3 groups, so the nurses and also the cleaners, they were positive, mostly cyclophosphamide. And the exposure was higher in oncology wards than the pharmacies, where pharmacy technicians and pharmacists work. So this is also a confirmation what we knew when we talk about the contamination levels. They are often much higher in the wards where nurses work than where patients where pharmacists and technicians are working. So the surface contamination was mainly observed on the benches, the bags, and on the gloves of the nurses. Conclusion of the study is very simple. The results show environmental contamination and exposure of the workers to these drugs. So it's not really that it's outside France, but it's also inside France that these studies, these results show exposure of workers. Bertrand.
Okay. En fait, je résumerai cette partie un petit peu à l'envers de ce qu'a présenté Paul. C'est-à-dire qu'en fait, je dirais que les sources de contamination sont très clairement démontrées, notamment dans l'étude française, où on met en évidence la contamination réelle des infirmières, parce que là, il parle des infirmières, avec quand même une fréquence de contamination de 17% des échantillons urinaires qui ont été recherchés dans cette étude, vraiment très importante. C'est la plus importante étude avec quasiment 1000, un peu plus de 1000 prélèvements urinaires réalisés. Donc, ce qui occasionne le fait que c'est vraiment une évidence, la nécessité pour nous de faire des prélèvements d'environnement pour déterminer quelle est la contamination environnementale de nos équipes qui travaillent soit dans les unités de soins, soit au niveau des départements de pharmacie. Je reviendrai sur 3 points ensuite. Le premier point, c'est sur l'étude allemande, qui est une énorme étude, 1700 prélèvements réalisés. Et c'est un petit commentaire que je ferai qu'a pas fait Paul. C'est-à-dire qu'en fait, on retrouve 27% d'échantillons contaminés au total dans cette étude. Et ce qui est surprenant pour moi, c'est qu'on retrouve 35% d'échantillons contaminés dans les unités de soins. On en retrouve simplement 15% dans les unités de pharmacie. C'est étonnant, pourquoi? Parce qu'en fait, dans les unités de pharmacie, c'est là où on manipule avec les concentrations les plus importantes et là où on a des surfaces de travail les plus faibles par rapport aux unités de soins, où ce sont des unités où on va travailler avec des produits dilués et avec des grandes surfaces de travail. Et donc, pour moi, on aurait dû retrouver des quantités opposées, en fait, plus de fréquences de contamination dans les départements de pharmacie. Ce qui veut dire quoi? Ce qui veut dire qu'en fait, nos techniques dont a parlé Paul dans les parties précédentes, que sont les isolateurs, les PSM, les façons dont on s'habille, les systèmes clos, permettent d'éviter la propagation des contaminations dans l'environnement, ce que l'on ne peut pas faire dans les unités de soins, puisqu'en fait, comme très clairement Paul l'a dit, le patient est le principal vecteur de la contamination de l'environnement. Donc ça, c'est un point important. Un point qui est capital, c'est l'étude hollandaise. Et donc ça, c'est pour tous ceux qui pilotent une unité de production des chimiothérapies, c'est des diapositives à absolument conserver, à appliquer dans nos pharmacies. Pourquoi? Parce qu'en fait, ça met très clairement en évidence comment est-ce qu'on doit interpréter nos prélèvements d'environnement. On a très clairement, alors même si le rationnel peut être discuté, mais dès lors qu'on a des niveaux de contamination inférieurs à 0,1 nanogramme par centimètre carré, on peut considérer qu'on est correctement, qu'on manipule de façon correcte et qu'on est en alerte dès lors que l'on a des concentrations qui sont supérieures à 10 nanogrammes par centimètre carré sur nos prélèvements. Ça ressemble vraiment beaucoup, pour ceux qui sont radiopharmaciens, à ce que l'on retrouve en radiopharmacie ou en médecine nucléaire. On essaie d'aller au plus bas possible et là, on a vraiment des indications sur comment piloter. Si on a des contaminations importantes en alerte, eh bien, on doit mettre des précautions supplémentaires. Pourquoi ne pas utiliser les systèmes clos, par exemple. Et puis, le dernier point que je dirais sur ce résumé de cette partie, qui est le cœur de la présentation pour moi, c'est très clairement la mise en évidence de l'efficacité des systèmes clos avec les différentes études qui ont été menées, notamment aux États-Unis, avec une diminution frappante des contaminations d'environnement avec l'utilisation de ces dispositifs. OK, Paul.
Okay. Now we move to the last slides. I will end now with some conclusions and recommendations, and I just summarized it a little bit because there are many things to conclude. But what's important to know that cytotoxic drugs are spread during preparation, administration, patient care, but also waste handling. So it's happening everywhere in the whole process. And we have still studies showing that people are exposed to these drugs. So workers who are dealing with these drugs are exposed. We need to check these files, and it's important because the vials, drug vials, can be contaminated on the outside. So if you take vials in your hands, always have gloves on. And skin exposure is a very, very important exposure route. So whatever you do with touching surfaces or that could be contaminated, have gloves on to protect yourself. But also when you do preparations and when you do administrations, change them frequently. And be aware that whatever you touch with these gloves can be contaminated too. Relevant, very important, is never open systems, never open and disconnect systems. Avoid open connections to do that because it will always result in aerosols and contamination and spread of contamination. Avoid patient's toilet, never go to a patient's toilet as a staff worker. It's for patients, it's not for technicians, it's not for pharmacists, it's not for nurses. Never go there. Closed system drug transfer devices reduce surface contamination and indirectly, of course, exposure of healthcare workers. Many studies show this, but there are also other advantages of CSTDs, and there are also more studies showing the advantages. So it's not about safety and health for workers, but it's also that you can reduce medication waste with CSTDs. You can reduce drug shortages and you can decrease the expenditure. So there is also savings when you implement CSTDs. Surface cleaning remains necessary. You have to clean surfaces because they will still be contaminated. And routine monitoring is really recommended. Wipe testing can give you a lot of information about your procedures, about cleaning and so on. And indirect works fine to protect yourself. In the end, I think it's also important that a lot of people think that there are no risks when you deal with cytotoxic drugs, but that's not true. There is a real risk of handling cytotoxic drugs, so we need to be aware that this is very important and we have to be careful and protect ourselves. So my conclusion actually is, and that's always what I end with, if you want to really make improvements in terms of safety, then you have to be sure that you have clean vials from the beginning, because when they are not clean, you start with the problem of contamination. Then use closed handling to protect yourself. And in the end, it's also important to train the staff. It's a continuous process of training staff, nurses, technicians, about being informed about the risk and potential exposure to these cytotoxic drugs. Bertrand.
Difficile de résumer en quelques mots pour gagner un petit peu de temps. La voie cutanée, c'est la voie d'exposition principale. Globalement, on se protège avec les équipements de protection individuelle, les gants changés très régulièrement, la formation, l'évaluation du personnel, l'utilisation des systèmes clos, et puis la nécessité, bien entendu, de faire de la surveillance de la contamination de l'environnement par ces web samples. OK, Paul.
Okay, I would recommend you to read this document. It's available. In this document, you can see more or less an update about the situation with cytotoxic drugs within Europe. It's a kind of a summary. It's in English. You can download it from the website of the European Biosafety Network. You can find it there. It's an interesting document. But what is relevant, because this document is the basis for changes, and these changes will probably come from the European Union. And what they did is they decided to look more in detail in the CM directive, the carcinogen and mutagen directive, to make a change in that directive specifically for cytotoxic drugs. And this is actually the whole process that is planned, but because of the COVID and the Corona crisis, it's a little bit delayed all. So we expect that in next year, early next year, the Commission will decide about how to proceed with cytotoxic drugs in terms of regulation, guidance, or whatsoever within the CM directive. And that can result in changes for the member states of the European Union, but also for maybe professions, pharmacists or technicians or nurses in their way they are dealing with the drugs nowadays. So that will probably come early next year. And this is actually where I would like to end my presentation with apologizes for, that something went wrong at the beginning, but thanks for your attention. And this is the greetings from our lovely island where I'm living nowadays. And if you have questions, you want more information which cannot be answered after this presentation by the questions, if you have future questions or whatever, please use this email at Palex to send to, so it will come finally to me and I will try to help you if you have further questions. And I would like to thank you all for your attention. Thank you very much.
Okay, so many thanks to Paul to the great presentation. Now Paul can answer to our questions. I read. Okay. Paul, can you explain the difference between the filter on the mechanical base CSTDs?
Yes, there are CSTDs who have a filtered system, and that is often linked to a charcoal filter. And the idea is that with these CSTD, air that gets out is clean, so it's not contaminated with the drugs because the charcoal filter is holding the drugs inside the system. And with a barrier system, it's a non-filtered system, so you don't have the filter, but it's the drug, the overpressure, that is mainly manipulated or handled within the system itself. So there is no risk for overpressure inside the system.
Okay. It is necessary to use a CSTD in automatization systems for you?
I think it's, if you can use a CSTD in an automation, I would do that, yes. But it depends on what automation you use. And I'm not sure if for every automation, the CSTD will fit. But if you can have a combination of automation where people do the handling and you have a CSTD, yeah, that's probably the most ideal situation.
Okay. Based on your experience, can you provide guidance on cleaning solutions that are the most effective without being toxic?
Yeah, I know cleaning is a very hot issue and it's also a very complicated issue. I remember that your French colleagues, Simon, I think it was Lille, he did a study on cleaning, and he has published that study. And I think that gives a good information about how to clean. So I would recommend that, but I don't have it in my mind directly, but I can forward it to everybody if needed. But there are some studies showing very effective cleaning, but cleaning should always be done in a few steps. So it's not one simple step for cleaning. You need probably more solutions to clean. And that has to do with the different physical and chemical properties of each of the drugs. For instance, when you want to clean the drugs like methotrexate, 5-FU-cyclophosphamide, it is often quite easy to clean, but when you want to clean the platinum drugs, which contain a metal, these are often more complicated to clean. So you need different solutions to have the optimum cleaning.
Another question. Dear Paul, do you have studies concerning the failure due to illness working with hazardous drugs?
I think I have, yes. Yeah, I have, but I don't have it here.
Okay.
But I can forward it. So if the person who wants to have it, just send an email to Palex, then I can provide it. It's no problem. I will do that.
We have another question. Many pharmacists in my area believe that when working inside the isolator is more than enough to protect yourself, and CSTDs are too expensive and unnecessary. What will be your answer to this statement?
I think that whether you work in an isolator or in a biological safety cabinet doesn't make any difference. And there has been a study performed, I think, in the UK a few years ago in an isolator, which is showing that most of the products that are prepared in an isolator, so bags or syringes, are also contaminated on the outside. So that means that finally these contaminated bags arrive by the nurses, and you have the problem there. So I see no differences when it comes to an isolator or cabinet. So I think in both cases, a CSTD could have an additional positive effect.
Okay, perhaps the last. How do you clean the vials? The vials,
yeah. I think you should do it in just simply with a tissue and with a liquid. But the liquid depends, of course, on the drug. What a lot of people do is they use alcohol, but alcohol is not enough for removing contamination. So you need, I would suggest something like probably a little bit like a soap, something like that, soap solution, and now finally use alcohol. But I think also that information can be obtained from the French study done by Simon in Lille. I think he has a good option, good solution for this problem too, because it's more or less the same as cleaning cabinets or isolators. So you need the same liquids.
Impressive presentation. Wipe testing is not EU-wide mandatory. Hospitals clean before they execute wipe testing. What do you recommend?
I would recommend to do the wipe testing before the cleaning. And the reason is quite simple, because I think that you want to know if there is contamination during the process, during the preparation. And if there is, you have to do something to get rid of it. And when you do it after the cleaning, you only check the cleaning process, and it can be very contaminated before the cleaning. So I would always recommend to do the wipe testing before the cleaning.
Okay. Well, it's 6 o'clock. It's finished.
But maybe there will come more questions. If so, then just send it by email. So I can try to answer that.
Okay. Many thanks for your participation. I hope you find the Equashield webinar interesting. The replay will be sent to you by email. Many thanks to Paul for this excellent presentation and the laboratory Palex Medical for their support. Have a nice evening. Donc, toute l'équipe qui a aidé à la présentation de ce webinaire se joint à moi pour vous remercier pour votre participation. Donc, j'espère que tout le monde a trouvé ce webinaire intéressant. L'enregistrement va être adressé par email et bien entendu qu'on remercie énormément Paul pour sa présentation, toute son expérience qu'il a pu nous apporter ici et au laboratoire Palex Medical pour son soutien. Voilà, bien, écoutez, on vous souhaite une bonne soirée.
Bonne soirée. Merci. Au revoir.